my stance has always been, if you're arguing that there's no clinical effect of manual therapy, then you're wrong. Basically, you don't know the literature.
In contemporary physiotherapy, a professor at Duke University and former editor-in-chief of the Journal of Orthopedic and Sports Physical Therapy. He is known globally for his work on musculoskeletal diagnosis, orthopedic examination, and the mechanisms underpinning manual therapy. With more than 350 peer-reviewed publications and several widely used textbooks, he has brought clarity to domains that were historically clouded in tradition, especially the diagnostic accuracy of special tests and the true effects of manual therapy. Professor Cook's work has helped clinicians understand the important neurophysiological, contextual, and patient-centered value of hands-on interventions. Today, we'll discuss the evidence for manual therapy, the myths and misunderstandings that surround it, and where he sees the future of hands-on practice in modern physiotherapy.
Okay, so today I welcome Dr. Chad Cook. So thank you very much for joining me today, Chad.
It's my pleasure to be here. Thank you.
Okay, so we had a recent correspondence over email, and you said that you'd been over to Australia, and that there was a big movement away from manual therapy there. And that kind of fits in with, at the moment, there's kind of a bit of a movement online of a demonization of manual therapy. Why do you think that's happening?
Yeah, so, and with respect to Australia, I probably had 30 people come up to me and mention that. So I'm going off, my encounters from people. There may be some differences of opinion on that, but it sure seemed to be that a lot of the educators and clinicians are moving away. With respect to why, there's probably, honestly, there's probably 20 reasons, maybe more. If we looked at the biggest reasons, I think obviously there are some concerns around how manual therapy is framed and what it does, and which are based off a lot of older philosophies that maybe haven't stood up in the literature as well. I think it's pretty clear that we've had some social media personalities that are very good at interacting with people. They have good product on social media, and they have taken a stance against manual therapy, which has led to a lot of followers, thinking the same way. My personal opinion is it takes quite a bit of effort to learn to be a really good manual therapist. There's a lot of psychomotor skills involved, and maybe there's a cost element to that. Maybe there's a time commitment element. Maybe people they don't think the juice is worth the squeeze on that. I don't think that's the case, but I think that might be one of the reasons. And I also think that maybe some of the major movers in manual therapy probably we didn't do as good a job in the last 2 decades in really framing what it does and how it has clinical efficacy and effectiveness. And maybe they needed a little bit of a nudge to get out there and show that that's actually there is actually quite a bit of evidence on the clinical side.
Yeah, so I was kind of going to touch on my understanding as I was taught, like I think I said to you, like 20 years ago. So we were taught that there was two main ways in which manual therapy helps. So we had the old Melzack and Wall pain gate theory and that mechanism, and then there was the DPAG VPAG kind of the endogenous opioids being released. What's our current understanding? So have we moved completely away from that? Is there still elements of some of that involved in what we understand to be the mechanism?
Yeah, so there's quite a. It's interesting. At Australia, I actually presented the mechanisms of manual therapy, and you may or may not be surprised. There's over 1,000 studies that have actually looked, and these are preclinical animal asymptomatic studies that have looked at what actually happens when we do manual therapy, when we do a spinal manipulation, what happens in the brain, what happens at either the regional or distal tissue level, what happens at the spinal cord. So there's a lot of evidence around this. We published a summary of this evidence in PLOS ONE in July of this year, and the first author's name is Damien Keeter. And the first thing I want to say about that publication is it shows how complex that interaction is when you provide a manual therapy technique and all of the different interactions that occur at the body. So there's no simple way of saying it does this. And there's so many interactions, Brad, at different systems levels or different biomarker levels or whatever. So what we've tried to do is summarize this. I mean, it does have a very strong pain modulatory effect. I mean, there's no question about it. There's heaps of literature. So the way that you learned is still supported within the literature in preclinical and animal studies. It also has an anti-inflammatory effect within the literature. It has a muscle relaxation, muscle performance effect that's well supported within the literature as well. There's some effects on the neuroimmune system, etc. The challenge is we don't know how many of those individual isolated biomarker assessments actually are the reason why we see clinical outcomes. That part has been really poorly studied. We just finished a systematic review, Brad, and there's only one study that has actually looked at those mechanisms and are the reasons of these mechanisms why we see clinical outcomes. So that part's a huge gap in the literature. But with respect to what happens, a lot happens. And it's probably so complicated we may never even know it. Never even fully figured out. It's like exercise. There's so many systems that are influenced by it.
Because that kind of leads on. I was going to say something about that as well. Is like, I know this is going to sound ignorant, but almost does it matter? So like, we're rarely going to sit in front of a patient and say, because of your dorsal and ventral periaqueduct, it works. And does it matter? Does it matter how it works? Or is that important for us to study so that we know for the future? Does that make sense? So is it important that we know exactly how it works, or do you think we'll never know?
So I appreciate you bringing that up because I've had a lot of people say that to me, and it's often people from other disciplines that use manual therapy. They say, "Why do you even care? Why is this even important?" I think it's important to justify mechanistically what we do with all of our interventions, right? Even our behavioral interventions. It's what exactly is happening with this? What do we know? Are these? Is that encounter and the things we assume, is that the reason why we're seeing the benefits with the patient? So I think there's some value to that. I think for the day-to-day clinician, you run the risk of just being swamped with, trying to explain something so complicated that the patients may not really even care about. So probably putting together, an isolated macro of, well, here's what we know. It's wonderful pain modulatory effect. It also promotes movement and allows us to move toward exercise and other components, which we know it does that, and it does that in preclinical work. We don't know if that's why it works in the clinical trials, but it probably is one of the reasons it works.
Yeah, so I think you've mentioned before as well, kind of a window of opportunity. So we're getting the move in, and kind of how we're doing that. It's the kind of getting the moving and restoring the normal movement that's the important thing.
Yeah, so that needs to be studied further too. I've heard this concept of window of opportunity. People will frequently ask me, when do you stop using manual therapy and then start using exercise? I tell you, to me, it's a blended approach. I do both. I do both always pretty much at the same time. It's just at different percentages and different levels of emphases and with a different communication strategy with the patient. I know that a lot of people think that when I was taught, right, when I went through my training program, I was taught that it's almost a window of demarcation here. You stop with the passive and you move with the active. But nobody really does that in clinical practice. We've looked at big data, of 50,000, 170,000, and it's typically blended. The average clinician tends to blend this stuff together.
Yeah, and then it's that almost getting that buy-in from that patient as well. That look, if I can kind of alter the way you're moving here, that's going to affect how painful it is to squat or to do that movement with your shoulder, and kind of it helps to kind of validate what we're telling them and get that buy-in, I think, as well.
Well, it's a very powerful thing when you can change the pain of an individual. And if you think about it, where we are positioned as physios, I'm a physical therapist, there aren't that many professions outside maybe chiropractic and osteopathy, that can make that instantaneous change in a person's pain or pain during movement. That's a really powerful thing for a patient, especially someone who's been battling something a long time and hasn't seen maybe the levels of success with self-management or medication. So, that part of it, I think, is kind of one of the hidden gems of using any type of hands-on incorporating manual therapy to movement.
So that kind of brings me on to, it's kind of a bit of a battle. I've been having a little bit of inner turmoil with this as well. So obviously we're taught, I think I told you, my original degree was sports therapy, and now I'm doing a master's in physiotherapy. So we're being taught these things again of the PIVMs, the PAVMs, being very specific with what level of the spine we're targeting. I think you'll say that we can't be that specific. Would I be correct in that assumption that we can't be, your L3 is the cause of your back pain, so we can't be that specific in our diagnosis?
Yeah, there's all kinds of issues with that, specificity approach that we've been traditionally taught. I mean, if you look at the clinical trials, almost every single one will say that you don't have to be specific to still see the benefit, a clinical outcome with a manual therapy approach. It's very clear in clinical trials in the average treatment effects that you don't have to be clear. In fact, there are a couple studies that actually suggest that if you're not specific, if you move away from the area when you're dealing with maybe different pain types like nociplastic pain, that you'll probably be better off not getting right on that segment and mobilizing it. And that's when you're looking at average treatment effects. I think the challenge is that we try to incorporate something from the literature to that patient in front of you, and when you're dealing with a patient in front of you, you're more interested in individual treatment effects. So there may be some patients in which that specific intervention is actually really important. And my gestalt says it's probably 10% of the people, which is one of the reasons it doesn't tease out very well in a clinical trial. But you've seen it, I've seen it, whatever, that sometimes that very specific, and I think of cervicogenic headache as a classic example of that, of managing, the specific pain level. That is important. So that's the conundrum that I think we deal with. The second piece to this is, are we really moving only one segment, or if we lock out below and above like we've been taught, are we really isolating the movement? Functional MRI studies suggest that we're not, and we're moving. It's a cascaded movement of features throughout. And if we know anything from the mechanisms literature, there's so many interactions too that it's unlikely that we're going to get one mechanistic response. It's likely to be an interaction of multiple mechanistic responses, which are going to be different from person to person. So being able to assume that if I do this one way, it's this specific thing is going to happen, it's just not realistic.
So how would you say because this is where my brain starts to get boggled, is then when we do things like our Mulligan's techniques or mobilizations with movements, there will be a specific segment. I might be trying to do my Mulligan's movement at that level. If I go down, pain's gone. How might something like that work? Because that, although we're not, we could look at a back and kind of blindly do it by touch and palpation in terms of, does that hurt when you do that flexion movement? How might that tie in?
Well, I think that's an individual treatment effect, and that's the individual variability that we see with our patient, and we've seen it a lot, right? I've learned, more Maitland based, and I've been told to go in, you identify the segment, you mobilize, and you'll see this pattern, but it doesn't always occur that way. It's often very different from person to person, or I may have to adjust the direction, I may have to go to the other side, I may have to go level below, and these are all individual characteristics, and also demonstrates that you have to be somewhat of an adaptive clinician and not get so regimented in your approach. A better understanding would, a better manual therapist would be understanding what a good response is from their technique and modify the technique as needed to get the response that you want. the challenge is that some folks, when they learn these programs, they're expecting to get an A to Z. This is exactly how you have to do it because it was taught that way for so long, right? That I remember the instructors going around and smacking you on the hand and saying that's not right. You need to change your angle. And we know now that that's just not how humans respond to an application. But getting back to what you ask, I think it's an individual treatment response, and it's up to us to really hone in on that to see if we can find the right one for that particular patient.
So again, this is me just wanting to learn from you. So if we're kind of moving a little bit more away from that Maitland, looking at our accessory movements, we've found which one we think is stiff. We can then either use that as our treatment modality, or we can progress on to, for instance, a Mulligan's type technique. Is there a different way that you would say to assess someone? So rather than having that kind of quite strict Maitland's technique of going through each vertebral segment, is there a better way? Is there a way that you found works more effectively than that?
So my understanding is that and I haven't taken Mulligan courses. I really respect the work they've done on the research side of it. They've done a really nice job. But having spoken with Brian Mulligan and other Mulligan instructors, they will say that they follow a very Maitland-esque assessment. So I tend to kind of combine the two together, have a very similar philosophy on the assessment side. I think the assessment can probably be economized a little bit more. When you're traditionally taught, I think, to go in and assess all these different levels, maybe getting a little bit quicker, going toward the particular area, looking for the response you want. If you get that response, then maybe not spending as much time moving to levels above, levels below, etc. Maybe not doing as many passive physiologicals on the spine, with the exception of the neck. It seems to have a good response in the neck. Not sure about thoracic and lumbar. I really don't use those very much anymore in those areas. So maybe economizing that examination a little bit more. And what we train learners is now find that movement pattern that seems to make a difference. It seems to provide you with the response that you're looking for, and find a correlate to that is active. So teaching the person how to do a similar movement that is active, that's augmentative, where they can mobilize themselves, so they can do something as a home program to allow that to have a little bit better carryover. Spend more time on that than that longer passive session that we've been historically taught. I don't know if that answers your question, but that's the way we've been looking at it to try to economize it a bit more.
Yeah, and I mean, I can't remember where I picked it up. There's been lots of courses and things that I've gone on, and I've worked in different settings. So I think it was from osteopathy that they called it like the doorbell technique, where rather than even looking, you're pressing down and they'll go, ouch, that's the level. So rather than being specific, it's L1, it's L2, it's just where does it hurt there, right, and then we can start to do our treatments from that point. So that's a little bit more of that generalized, I think.
I think it's fascinating, and I used to kick tires. I would go to all the different manual therapy courses and just learn the philosophies and hear the history behind it and how they do their assessments. And I remember sitting there thinking, okay, I'm not sure I buy a lot of this, but it's interesting to get that input and then collect all that information together and then maybe combine that into more of an eclectic approach that works for you, your thoughts, and your hands. So I like the fact that you're kind of grazing around and trying all these different ones. I think it's, I've quit doing that, so I kind of miss that piece. So.
Yeah, it's kind of, the way I was taught it is kind of get as many things in your toolkit as you can, and then you can kind of, you've got more that you can attack things with. Okay, excellent. So is it important from a treating a patient point of view that we understand exactly what it is that we're doing, or is it more important, like you said, the movement patterns and the kind of their easing factors? Is that more important than us knowing exactly why what we're doing is working?
I think it depends. If you're a researcher and your goal is to get funding and to explain things, I think understanding the mechanisms and what's actually going on should be the primary importance. So, if a person's primary role is that, then they're probably going to be digging into, the science behind the mechanisms. As a clinician, if your primary role is to improve patients' overall outcomes, I sometimes think that some of that is noise or it's superfluous. Um, in that case, what I would do is focus on understanding what a positive response is, but also looking at other key features in that examination that suggest that adjunctive treatment options might be useful as well. That's where the clinician can really, I think, bank and improve moving forward. Um, when I present, because I'm primarily a researcher now, so when I present, I have to walk a very careful line of being a nice to know, here's all this stuff that is going on, and here's what's happening in the brain, and blah blah blah, versus actually this is the most important thing you need to recognize. This is a positive response. This is a negative response. This is a response that suggests you should follow up with this. This is not. So that's how I look at that. I think some of it, again, very useful for researchers, especially those that are pursuing funding lines, but for the day-to-day clinician, probably isn't, other than being interesting, probably isn't that important.
I think I was being a little bit selfish there because I would quite like to go into research. Obviously, I'm going to have a master's dissertation, and university that I'm at is very big on research. So I was kind of trying to pick your brains there a little bit of where should we be looking? Where are the gaps for us to research into, or do a lot of that not matter?
Well, Brad, I think response patterns is a huge gap. So here's what we know. We know that there, because I've done a lot of work in this area initially in the earlier part of my career, is there a response pattern on that first day or that subsequent day of change in symptoms, change in pain, how quickly that actually occurred with certain movements? Is that prognostic for a good outcome? And it's similar to what the McKenzie folks look. If you see early centralization, it's a prognostic for a positive outcome. There's still work to be done in that area of identifying different, and we'll call them clinical response gaps, that suggest a person is, going to have a good outcome. It doesn't necessarily suggest that that person only would benefit from that technique that was used. It probably suggests that the person in themselves is going to have a better outcome. The next step, the holy grail, would be differentiating between, all right, this response says that they're a manual therapy candidate. This response suggests that they're not. We haven't gotten there yet. There's still a lot of work to be done in that area. It's really difficult research to do. That's moderator research, and it's expensive, and you have to have a lot of subjects, and it's complicated.
Yeah, okay. So hopefully I can glean something off of that for my dissertation, and head in the right direction. I think we all want to have that kind of answer, don't we? Of go, the Brad Watt technique, yeah, that fixes everyone's pain, and the reality is that there isn't one, unfortunately. So I think kind of leading back to what you were saying about the way we approach things from Maitland's, Mulligan's, however we approach Mackenzie. Do you think we need to change the way we teach manual therapy? So do you think there should be an overhaul in how it's taught? And to caveat that, while you're talking into kind of where, like where should we be going? I know that's quite a big question.
Well, it's a great question, and I'll give you some backstory on it. We did, Damien Keeter, me, and a few other people actually did a series of 3 papers where we ask expert clinicians, based on what we know, the new evidence that's out, what should we keep in the training and what should we add? And the problem is they wanted to keep everything and just keep adding things to it. And we already have training programs that are really long and burdensome in some cases. So if we didn't get the answer that we were really looking for in that, do I think we should overhaul the way we manage it or the way we teach it? Absolutely. In fact, there's a special issue in one of the journals that's actually looking at education in manual therapy. And I talked to him last night about writing a viewpoint around the idea that we should probably teach 12 techniques, get good at those, have those psychomotor skills, understand what they do and what the appropriate response is, and that should be the base. And if a person really wants to go above and beyond that, they can do additional trainings, but the training levels should focus on less techniques and more understanding of what a positive response is and how those adjunctive care processes are baked into the treatment. Now, that's easy for me to say because, as you know, it takes a while to learn a complicated technique. It's a psychomotor skill, so you can't just go to a weekend course and learn how to do effective manipulations. Typically, it takes a while before you get that down. But I am a believer that we probably teach too many techniques. Teaching 5 ways to manipulate the upper thoracic region. I don't think we need to know that. I think refining it down, focusing more on, if you're going to do this, this is the response you want, and then how do you bake that into, an augmented, complementary, well-rounded program. That's what manual therapy should look like moving forward, in my mind.
Yeah, no, that's great. I mean, I kind of saw that idea briefly taught in secondary schools, and the syllabus is what you're saying. Like they're teaching science, and they're just adding and adding and adding, and then you've just got this real breadth of knowledge, but no depth into one specific thing. So no, that's an interesting way of looking at teaching. And then I suppose then it comes into that adaptive part that you were saying, that then once I know that this happens when I do this, if I just change it a little bit, I would expect the response to be kind of targeted somewhere else.
Don't you think, Brad, that that's the expert clinicians that you encounter is they have that ability to adapt, and they have that ability to recognize when something's working and when it's not, or how to adjust something to make it work better. I see that I work a lot with clinical psychologists, and I see that on their end of it, that ability to really hone in on behavioral elements and psychological components that seem to really trigger the patient into understanding things and understanding their role in the recovery process, that sort of thing. And some people are very good at it, and some people are not. And the expert, the person who does really good, has that, that really breadth of knowledge. They're not just throwing out strategies. They're actually maybe 1 or 2 strategies, but really working those and getting the most out of them. I think a good manual therapist is the same way. We tend to, it's sexy to know all these techniques and, all these different ways of doing things. But to me, that doesn't make a really good clinician. That's somebody who just knows a lot of techniques. I see a lot of courses that are taught that way. It's like a technique fest. I don't think that's really the way we should go. And it's the same with exercise, learning 5,000 different ways to strengthen the shoulder. I'm not sure we need all that either. So that's just kind of the way where I've gotten to, and my colleague Chuck Thickman, he says, this is a very American phrase, it reflects American football, but learn to block and tackle well. And that's basically the bare minimum things you do in football. But if you do those well, you're pretty successful.
Yeah, that was kind of one of the things when I was thinking of questions that would really kind of utilize your knowledge. Is I started out as a personal trainer a long time ago, and we saw that with the fitness industry of like you went from being the army style boot camps, and then there was like Arnold Schwarzenegger and the bodybuilders, and then there was a bit in the middle there, kind of going into the 90s, early 2000s, where we just made things so complicated. Everyone was on a BOSU and trying to balance on one leg and doing things. And then it's kind of all come full circle again, and now it's boot camps, kind of your CrossFit style training, which is kind of your old school, really, like doing the proper movements and doing them well. So yeah, do you think there's an element of physiotherapy that we're going to be moving kind of in a circular fashion, or where do you see the future going?
It's a great question, and so my wife is a physio, and we were talking about that this morning, and I think that, and we were talking about the study that recently came out, that there's been a lot of recent graduates in the United States of physios who have just really been discontent their first year getting out and realizing that it's not what they thought. I think because of the burdens on most of the clinicians on how many patients they have to see, the the speed in which you have to see patients now, the rapidity of how quickly you have to manage someone, I think you're going to have to get back to the basics and really paring it down to what works and what can be done, and also what the patient will do. So yes, I do think you're going to get back to more of the basics, more of the boot camp approach, I guess, is a good way to look at it. But yeah, I just don't think we have the time and ability to spend some of the, to the more complicated components. I don't know how these talk-based clinicians actually get it done. In the United States, the amount of time that we get to see a patient, how many visits, just keeps going lower and lower. In the VA, which is a large, veterans healthcare system within the United States, the median number of visits for low back pain is 1. I mean, I just don't know how you're going to take a very convoluted, complicated program and incorporate that to a patient when you just don't have the time, and you just don't have the patients just don't have the finances to pay for those things. So simplicity, self-management, that's the best way to go.
And I think that we talked about it right at the very start, that demonization of manual therapy, and that whole, a lot of people, especially on social media, that are naysayers, that doesn't work, that doesn't work, that doesn't work. That can kind of lead into that, because then you become disillusioned that, well, why am I even doing it then? Why does it even matter? And then you're losing physios that mean that we're more stretched. So it's kind of, you're biting your nose off to spite your face. You're kind of discouraging people from learning that trade, which I find confusing.
So Brad, one of the things I did at Australia was, because one of the big questions, and what I hear a lot on social media, or people have added me before and said, why do you advocate for something that has no clinical value? Well, that's a person who doesn't know the literature. So at Australia, I actually presented 74 systematic reviews on manual therapy, and these are manual therapy versus usual care, manual therapy versus exercise, manual therapy versus whatever. 74 that showed that manual therapy was as effective or superior to the comparator. 74 systematic reviews representing 900 different clinical studies, some trials, some non-randomized trials, etc. 900. Now, the way I framed it is, look, there's a wealth of literature behind this. There's no question anymore that it has an effect. It has a clinical effect. Even if we take 80% of those systematic reviews or those clinical studies and say, they're garbage, they're high risk of bias, low quality, whatever, low certainty of evidence, you still have 15 systematic reviews supporting the use in clinical practice and about 140 clinical studies. I mean, most interventions would love that kind of evidence of support. So, my stance has always been, if you're arguing that there's no clinical effect of manual therapy, then you're wrong. Basically, you don't know the literature. So, I think most of the anti-manual therapists on social media now are more about what the claims are of what manual therapy does, and I understand their concern there, because there's a lot of weird stuff, right? There's a lot of things that have been claimed in the past. There's a lot of information carryover from the past that we're still saying, this is what it does, and it's just not true. That part of it needs to be kind of cleaned up. We'll get there, I think, at some point. But the clinical side, I just want to reinforce that, there's heaps of literature on that. That's a non-issue.
Yeah, and I think it goes back into what we were saying earlier of, even if it is placebo, if we're saying that this biopsychosocial model is what's the key to it all working, then me taking control of your limb, moving it pain-free, that perpetuates that and gets that buy-in from that person, which would then just amplify the placebo effect. So it's kind of win-win, I think, personally.
Yeah, we know it has a therapeutic effect, so it's not completely just a placebo effect. We know that a person's preferences, values, and beliefs may amplify that, which would be the placebo effect. It may bump up that therapeutic effect. I always step back and think about, well, what is evidence-based medicine really, right? It's evidence, right? It's just literature. It's stuff you pull from the articles. It's also your um, capacity as a clinician, your expertise, your experience, and understanding what the patient needs. But the third part is patient values, beliefs, and preferences. And if you look at the literature, when they've asked patients, what are you expecting from your physical therapist? What are you expecting from your chiropractor or osteopath? Well over 50% expect some form of hands-on intervention. So if a person can benefit from that, and you, because you read some social media post or a blog or something, and you decide not to do that, well, that three-legged stool, you're skipping one of the legs of the stool. So I always ask my patient, what are your thoughts around this? And then share what I think might be beneficial for them, and then go from there. But patient values, beliefs, and preferences, that's one of the first questions I ask when somebody says, well, I never use manual therapy. I said, really, how do you address that piece of it when somebody comes in expecting that? Knowing that there's evidence to support it, how do you actually, what do you say? What's that encounter look like? That's their choice. They're the clinician, but, that's one of the things I want to know.
Yeah, and I know from my own personal, when I've had injuries and things, I would kind of feel a bit robbed if I went in and sat down with someone and spoke about my injury, and then after explaining everything, they went, "Okay, see you later." Then I would kind of be thinking, "What are we doing?" And I know there is a lot of benefit from teaching someone how to take ownership of it themselves, but I want like a little click or a little stretch or something to make me feel like I've got something out of that treatment session, personally.
I, I think you're like most patients. Yeah, I think I think a good clinician can do both, Brad, and that's the key, right? It's you can do the things that um, accelerate the process. I think the mistake that can be made is if you focus too much on that and not enough on the, hey, let's talk about how to manage this on your own, or if this comes up again, what you can do, or let's talk about strategies so that you don't get a relapse or a recurrence of this. I mean, to me, that's good therapy, is the ability to do that. I think the best clinicians blend the two together, and use a hands-on approach as a combined intervention with other strategies. I think the talk-based clinicians probably are very good at that, but I think the real power comes when you can incorporate talk-based care with the hands-on and the exercise. I mentioned earlier I work a lot with clinical psychologists, and they all say the same thing to me. They said, you're so lucky that you can put your hands on patients. We can't do that. And sometimes that little extra push, that little extra, if we could just do this, is what that person needs. We have such breadth in our profession that we can do that. I think I like how we're positioned within the healthcare industry to be able to cover an area that other people just can't do. So I think all of the interventions are important,
Yeah,
not just one or
fantastic.
two. I don't believe in extremism. I don't discount this because I don't like it, or always promote this or whatever. Somewhere in the middle, using a combination of things, and that's probably the right approach.
Yeah, yeah, no, and I would agree with that. Obviously, your opinion counts much more than mine, but that's what I've seen is yeah, rather than saying it's all about exercise, it's all about active, passive. It's a bit of everything. Yeah, sometimes it's appropriate for one and not for the other. So I don't want to keep you too long. So I've got two more questions that I wanted to ask you, and they're quite long questions. Like I like to chuck in a little extra to them. So one is just things that you'd like to see more of, things you'd like to see less of, and then the last bit is going to be some advice to a student. Like I said to you, I'm back to studying again, and hopefully some people on my course are watching as well. So kind of advice for students. So firstly, things that you'd like to see more or less of in the industry. So kind of a room 101 and a let's do more of this.
So I really believe in translational research, and there's very little of it. And the funding mechanisms in my country just don't fund translational research. They either fund just the clinical part or just the mechanisms part, but not that blended, aspect of it. I would love to see more translational research. If you think about a moderator design, you're looking at different patterns of baseline findings that are reflective of a person who may benefit from one treatment or another. I think we should focus more on those studies than just this versus that trials, A versus B, A plus versus A. I think we know enough now that of the interventions that have effectiveness that we should stop funding, big trials that tell us basically the same thing. Instead, let's focus more on studies that tell us who might benefit from one intervention or another. I'd like to see less of animal and preclinical work. I don't think we need to manipulate cats and dogs and mice anymore. We kind of know what happens to the tissue. What we don't know is if that is the reason why people get better, or can we extrapolate that to a human with low back pain? We need to move forward toward translational research and actually investigate that. That part's missing within the literature. So I'd like to see more of that, and a better understanding of where things go with that, and maybe less of kind of what we've been funding, almost out of pattern now. I'm almost out of just, this is what we've always done. So definitely that. The second piece to that is advice to a learner, a new learner, or even a person's not so new but is back into learning. I gave the same comment to one of my DSC students last night. I think curiosity is the most powerful thing that we can have as a learner. And that curiosity should allow you to dive deep into a topic and explore it from A to Z, and to know it from every angle, and to really understand it in a way that others haven't even closely tapped into. And the colleague that did some work on patient preferences, patient expectations. And to me, if you're doing a study on patient expectations, you should be the smartest person in the room on expectations and know the strengths and limitations and all the different angles around that. Same thing with if you're doing a study on manual therapy, if you're doing a study on a certain type of exercise or whatever. Let your curiosity allow you to dig. There's never been a time in our life in which when gathering data and getting information has been easier. And guiding that information learning process with AI has been more effective. So we're at a place where we can really start pulling information to better understand these concepts rather than, just reading a blog or listening to somebody's opinion on Twitter or something like that. Be your own learner and dig in and really understand the strengths and weaknesses of every argument. That's what I would recommend for new learners. They're the best kind because they always find that things kind of move toward the middle, and there are pros and cons of every argument. And otherwise, it wouldn't be worth learning. It would be a truism. So that's what I would recommend: curiosity and digging deep.
Amazing. Well, I'll let you go at that point and just say thank you very much for your time. And it's been a pleasure to speak to you, and just trying to pick into some of your knowledge, just a little scratch.
Brad, it's been my pleasure. We've been chatting over the last couple of months. I wish you the best of health, and also really good luck with your training moving forward. I really appreciate what you're doing and being an outlet for different individuals such as myself.
Amazing. Thank you very much.